it's easy to introduce Poppy. She's an outstanding DPhil student. What she's done wonderfully well is to combine understanding and treatment. So in her study, she's helped push on the understanding of how the self-concept has a role in the cause of paranoia, and use that knowledge to test new treatment techniques with precision, really. And these have been tested now with patients with persecuted delusions and are showing potentially large effects. So there's a real practical outcome of the work she's been doing. She's already published 5 studies from her PhD, but perhaps more than anything, what's very striking about Poppy is just her dedication to mental health, and I think you'll hear that in her talk. It's a very clear commitment and dedication to the area, but also she's brilliant at supporting all those other people in the team. So she supports so many other people whilst also carrying out outstanding work. She's sadly almost at the end of her PhD, but the very good news is she's been accepted for training in clinical psychology at Oxford. So she's going to do that, and I'm sure in the future she's going to be a star clinical academic researcher, I hope. So over to Poppy.
Yeah, as Daniel said, I'm now in the 4th final year of my PhD. And today I'm going to be talking a little bit about the work I've been doing around implementation and policy. So not presenting results as such, but thinking about how I've been trying to take the research a little bit further. But firstly, a bit of a recap of what the first 3 years of my PhD focused on. So as Dan mentioned, I ran a series of randomized controlled tests of specific treatment techniques for reducing paranoia. I also used network analysis, so a special kind of statistical technique, to look at the associations between parenting behaviours and paranoia. And throughout my work, a big focus has been using virtual reality as a tool in research and clinical practice. But in my final year, I've really turned to the question of how findings can actually be implemented into services to really be actually making a difference to the people who need it. And there's 2 ways that I've been thinking about this. The first is through qualitative work, and the second is through policy work. And it's those 2 things I'll be talking about today. So one thing I know from my own work and that of my team and others in the field is that automated virtual reality therapy has the potential to allow many more people with mental health problems to receive precise one-to-one evidence-based therapy. So I designed a qualitative study to assess the feasibility of implementing virtual reality therapy into a setting where delivery of any psychological therapy is the most limited, which is psychiatric inpatient wards. So this is the Warneford Hospital where we're based in Oxford. And to set the scene, I'd just like to introduce you to Damien, who said, "We just get filled with pills. There's no talking therapies or anything like that." So Damien is one of 18,000 adults currently in a mental health hospital. Psychological therapies such as CBT are recommended for almost every mental health problem, even when problems are severe, due to its proven cost effectiveness in increasing recovery. But access to psychological therapy on inpatient wards is quite limited. Medication is the primary line of treatment in most cases. Inpatient care is nonetheless the most expensive form of care, with each bed costing up to about £180,000 per year. And this is the equivalent of supporting 44 outpatients through a community mental health team over a year. The expense of inpatient care has led to a reduction in the number of available hospital places. The number of beds for adults in England has fallen from 70,000 to just 18,000 over the past 30 years. And the consequence of this, well, firstly, there's quite a lot of pressure to meet targets for reducing bed occupancy, which in turn leads to a focus on acute symptom reduction rather than recovery and preparedness for discharge. Problems are compounded by a lack of trained staff, a reliance on agency staff, and really quite high levels of staff burnout. And so unsurprisingly, there's often limited time for much meaningful staff-to-patient interaction, and in general, a lack of meaningful activity of any kind for inpatients to engage with. As Dan describes, he said, "All you did was just sitting around and there was nothing for you to do, no program to keep you busy. It's not good. I stagnate." Of course, this isn't always the case. There exist many wonderful people, dedicated staff on wards, really keen for innovation, who are trying to change and improve things for people who really do need residential care as a crucial part of their recovery. And some amazing work has been done. This slide just shows very few of these. But I think one of the challenges that remains is how we can increase the provision of psychological therapy when there are shortages of trained staff available to deliver it. And one solution to this problem may lie in virtual reality. So difficulties interacting with the social world really lie at the heart of many mental health problems. So for the people I work with psychosis, they often find everyday situations like going to a GP surgery, visiting a shopping centre or a cafe extremely frightening. In VR, it's possible to enter simulations of everyday situations while practicing therapeutic techniques that help people to feel more calm, confident and safe. The scenarios you can see here from the Game Change virtual reality trial. So VR has a lot of advantages. Firstly, people are much more willing to enter the scenarios they find challenging because they know that it's only a simulation, it's not actually real. And that enables them to practice changing the way they think, react and behave in these situations. But crucially, the reason VR works is that we react psychologically, emotionally, and physiologically the same in VR environments as in the corresponding real-world environment. And because of this, we know that any learning that's made in VR transfers to the real world. In addition, a crucial part of VR therapy and why it can help with the access issue is that it can be automated. So this means that in VR with you, there is a virtual therapist who can explain the therapy to you and encourage you to try things out. So this is Nick, the virtual therapist in the Game Change virtual reality trial.
Welcome to Game Change. I'm Nick. I'll be guiding you through the program. It's great to meet you. The activities you'll try in Game Change are all designed to help you feel more confident, safer, and in control around other people. Before we get started, let's introduce you to the virtual world.
So because of this automation, the therapy can be quite easy to deliver to people. A highly trained psychological therapist is not necessarily required at all times. And because of this, VR therapy is a lot cheaper to deliver. And because of this, far more people could have access to psychological therapy. So the idea is not at all to replace psychological therapy delivered by clinical psychologists and other therapists. It's an additional tool that can vastly increase access to therapy to those in need. So the Game Change trial is a multi-site randomized controlled trial of VR therapy for psychosis with many wonderful and important collaborators I'd like to acknowledge, so particularly the McPinn Foundation, NIHR Mindtech and many others. So in my quantitative study that's looking at the implementation of VR therapy onto inpatient wards, I'm running focus groups with NHS staff and patients on wards at 5 mental health trusts across England. And in these groups, I demo the VR Game Change therapy and find out what people think about it. There's sort of 3 key objectives. Firstly, to explore staff and patient expectations of VR therapy before they've tried it, and then to get their feedback on after they've tried it. Secondly, to apply an implementation framework. So I'm using the NAS framework to assess feasibility of adoption. And finally, to identify if there are any differences across those 5 sites in England for feasibility of implementation. And again, I've been very fortunate to collaborate with Mindtech and McPinn on this study. So I began running focus groups just before the pandemic began last March, and of course had to pause since then. So I'm not able to share the results just yet, but I will just share a quote from one individual who reflected on what it was like to try the VR on the ward. So this is Simon, who said, "That was more than real. Although you sort of know that it's virtual reality, it does feel real. It's quite bizarre. I already feel as though I've been out today by just being in that experience." And the protocol for this paper is published in Journal of Medical Internet Research. So upon having to pause the study, I then turned instead to thinking about mental health policy. So that second way we can think about kind of taking research a bit further. So I spent several months working in the mental health policy team of the Department of Health and Social Care, working very closely with NHS England Improvement and Public Health England. I'm very grateful to Mental Health Research UK for supporting me to do this secondment. So a bit of a brief summary of what it was like, what I was doing. So essentially I was working as a civil servant, and most civil servants are generalists who have transferable skills across departments. They don't necessarily arrive in a team with domain-specific knowledge. Some examples of the work I was doing was working on a cross-government mental health action plan to respond to the mental health needs of the population following the pandemic. Also working on a mental health and wellbeing impact assessment. So that's for when other departments introduce new policies, creating a tool where they can actually think about how is that policy going to impact mental health, because we know mental health has many social environment determinants. I also led my team's engagement with stakeholders, and in particular, I tried to increase our engagement with experts by experience, so people with, particularly with personal experience of mental illness. I would write submissions for ministers and Secretary of State for Health, and because I came from an academic background, I tended to lead our team's work on any evidence reviews or notes that needed doing. So for me, it was a really insightful experience. I felt I was really able to contribute to a lot of important work, and now have a much better understanding of how to stay engaged with mental health policy and hopefully continue contributing to it in the future. So finally, just like to say thank you to my supervisors, Daniel and Felicity, and also to two members of my team who particularly contributed to the qualitative study, Sinead Lamb and Lena Rosebrook, and of course, a huge thank you to Mental Health Research UK.